today about transitions of care, and we'll spend quite a bit of time talking about the hospital setting, but also I'll tell you a little bit about some of the things that are happening in the outpatient setting as a prelude to some of the things that will happen later on in today's course. We mentioned earlier that there is no CE for this presentation. However, I will reference an article that was in March of 2013 in the Annals of Internal Medicine, and it was an article written by Christopher Kim and Scott Flanders at the University of Michigan, which does have CE associated with it. And after hearing the majority of my talk, you should be able to pass that CE pretty well. That's an FYI. For those of you who are looking at that. There were several things that I found incredibly exciting about listening to Kathy Kalicki speak. First of all, I did the thing you're not supposed to do, which is I went immediately to my iPhone and had to find that movie from 1997, Gattaca, with Ethan Hawke. Because she was talking about the genetics and how they were going to, I don't know if you've seen it, he's like a genetically inferior guy in this genetically superior world. So I immediately IMDb'd Ethan Hawke and Gattaca, and I had to tell her about it when she sat down. A couple of things that Kathy spoke about that we'll get to. So she talked a lot about collaboration and coordination, communication. She talked about the things that are going to drive our practice going forward. And so I'll spend some time talking a little bit about those things, and then really focusing on what we've found so far and what we're trying. In particular, if you think about what is driving our practice, 19% of people discharged from a hospital have an adverse event. And they usually have it within 2 weeks. Of those 19%, about a third of them are medication related. So when you think about the things that we do and the things that we can do around this particular part of the population that is leaving our hospitals or leaving our care, there's a lot of opportunity. In addition, when you start thinking about some of the things that Kathy was speaking about, she talked a lot about CMS, value-based purchasing, some of the things that are driving from a financial perspective. If you think about the adverse events that I just told you about, and you think about Medicare patients in particular, about $12 billion to $44 billion is what we spend on adverse events in this population annually. $44 billion. So I have a friend who works at the Washtenaw County Community Center, and she works in their finance department. One day I'm talking to her, I say, Ashley, what's the most you've ever budgeted or managed in a budget? She says, oh, I used to work for the House here in Michigan, and I managed $81 billion. That's billions with a B, okay? So I want you to think about that. Billions with a B, 44 billion that we are spending on adverse events. So when you talk about what's driving this, think about it. As Ashley would say, so you have to imagine this like blonde-haired ballerina wearing these like, cute little black glasses, and she says, billions with a B. So that's what I want you to think about. CMS came up with this partnership for patients and their goals. Two of the main drivers for this were to keep patients from getting injured or sicker, and to help patients heal without complication. And so they had a goal that by 2013, and at the end of this year we'll find out how we met our goal, that the transition of care and the adverse events, complications associated with that would be reduced by 20% compared to 2010. Eric Coleman, who's a guy, if you do that CE that I told you about from Christopher Kim and Scott Flanders, he'll come up several times in their references. Eric Coleman is a gentleman who he and his colleagues study transitions of care. And in studying some of their transitions of care, this was an article that was released in 2006. They looked at what are the 4 pillars that would make successful transitions of care. These are the 4 that they came up with. Medication self-management. And what he means by medication self-management is that a patient knows their medication, knows what it's for, and knows the triggers for when it's not working. The use of a dynamic patient-centered record. If anyone speaks to me outside of this room, or maybe even in this room during this presentation, you'll know that I'm a huge advocate of patient and family-centered care. And when he talks about the use of a dynamic patient-centered record, he doesn't mean patient-centered in the way that we follow a patient in our care. He means patient-centered exactly the way that Kathy was talking about. It's the patient's health record. They feel that they own it. They feel that they have some onus to maintain it, and they feel that they have the opportunity to respond when it alerts them to opportunities for them to increase their care. The third pillar is that you have to have primary care and specialist follow-up. And this begins in the inpatient setting. It begins with interdisciplinary rounds in the hospital. But you have to have a coordinated follow-up with the patient in future care. The fourth, going back to even talking about medication self-management, is that the patient has to know their triggers. They have to know, when do I know that I'm getting really bad? When do I know that I need to go to an urgent care or an ED, or I can just call the nurse? And they need to know this before they make the call to the nurse. They need to know, what are my triggers? If you think about some of the things we do in the outpatient setting, you can think about maybe an asthma action plan or the way you might educate a patient. And you're going to go over, these are the things that I want you to watch for. These are the things I want you to be aware of. This means you're in trouble. And he made a point of documenting these when he talked about the successful transitions of care. This is another article that was done in 2011 by Hansen and colleagues. It was in the Annals of Internal Medicine. They did a systematic review. They looked at 43 studies, and they kind of bucketed them into 3 different areas. There was pre-discharge, post-discharge, and then what they would call bridging. The thing that was really that really spoke to me out of this systematic review is that when they looked at all of these 43 studies, of which 12 had those different categories, there was no single intervention that was associated with reduced risk for 30-day rehospitalization. What that tells me is that we haven't found the answer yet. Or, in true pharmacist fashion, we haven't studied it correctly, right? So we haven't found an answer. So either we're not looking at it right, or we're just doing it wrong. So we have to figure out what the real answer is and what's out there. So the systematic reviewed 5 randomized controlled trials that had statistically significant improvements. 10 didn't show any significant effect with isolated or bundled. So what you'll often hear when you talk about transitions of care, someone will say bundled care or these isolated experiences. So maybe if a pharmacist called isolated from the rest of the care team. And 2 randomized trials found that no effect from post-discharge calls on isolation. And so when you think about the way that these things work and what they tell you, one of the things that this said to me is that calling alone, doing it on our own by ourselves, not only doesn't have any significant effect, but has actually shown that it doesn't work. It was found no effect. So when we think about the things that are driving our healthcare, collaboration, communication, the coordination that we talk about, these are the types of things we think about. So as we go through these presentations, I want you to keep those in mind. Collaboration, coordination, communication. This is another article that was released in the Journal of American College of Cardiology. Looked at 500 U.S. hospital surveys to determine the use of 10 practices. And so this is looking particularly at cardiology practice. The medication management practices, and there are 4 of them noted there, I want you to pay particular attention to the 3rd one and the 4th one. Almost 50% of the practices noted had no pharmacist or pharmacy technician involved in medication histories. When we start thinking about where pharmacy can get involved, this is kind of what I would consider like baseline. This is like saying I can do a drug-drug interaction evaluation. We should be involved in the medication histories and medication evaluation. It doesn't have to be us that go do it as a pharmacist. I'm a huge advocate of technicians in this role. And you'll see examples later where we talk about using students in this role. But it has to be done by pharmacy. There are nuances that you and I can appreciate that don't happen when someone else looks at it. And Kathy alluded to, she said, how many of you have seen a poor medication history that then went on to become a poor medication discharge medication list? It happens all the time. And it's not because people aren't competent or because they're not good people. It's just that it's someone else's area of expertise. And so you'll always hear me advocate for pharmacists enrolled or engaged in this. The 4th bullet, when you think about it, 3% to 14% made contact with an outside pharmacy or primary care provider as the MedRec process. That means that we have an 86% opportunity at best. So when we talk about how we get involved, no one's calling their primary care, no one's calling their outside pharmacy. How many of you have worked in an outpatient pharmacy or in a retail pharmacy setting? How many times have you had someone call you and ask you about a patient's medications? Thank you for those of you that have done it. It's a much smaller percentage. There is a huge opportunity to link the outpatient to the inpatient. As I was laughing to myself, as Kathy was presenting, I could see hanging out of your head. When I talk to residents, I say, how will you know that you've done a good job at the end of the day? If you ever wonder how you know you've done a good presentation, Amy Cho is not in your head. It's like the equivalent of, yes, right on, right? She's nodding her head. And I like to talk to Amy about where our practice is going. And she and I talk a lot about how can we link the outpatient setting and the inpatient setting. This is a huge opportunity. This article that kind of rocked my world, which came out in 2013, and I'm somewhat biased because I have the opportunity to work with at least one of these gentlemen often, article about transitions of care that came out in the Annals of Internal Medicine in March of 2013. It's a great article. If you know nothing about transitions of care and you're going to be an inpatient care practitioner, I highly encourage you to read this article. It's a very easy to read. It's done in a question and answer format, and I think it has a ton of information. Some of the things that they talk about in this article are the idea of an interdisciplinary bundle. And I talk about this because it's probably one of the most recent articles we have that really looked at transitions of care. They talk about the interdisciplinary bundle. And from their perspective, it absolutely starts with interdisciplinary rounds. So I know some of you operate in your rounds to identify medication issues and alleviate them before the patient leaves, but I encourage all of you to get involved in this process. One opportunity in particular would be around restricted drug distribution. If you're an oncology practitioner, so how many of you think you want to practice in oncology or are going to practice in oncology? Okay. If you are an oncology practitioner, I highly encourage you to be familiar and understand the restricted drug distribution pathway. For where I work, the oncologists who get involved make a difference in the transitions of care for those patients. Getting involved ahead of time can be the difference between an increased length of stay or delayed access to a medication. And so it's incredibly important that if you're an inpatient care practitioner, you identify opportunities to get involved in these things. Teach-back methodology, and this always makes me giggle a little bit. How many of you are familiar with teach-back methodology? So a fair number. If you look in the nursing literature, this is this like revolutionary teach-back methodology. And I feel like yeah, that's what they taught us in pharmacy school, right? You ask the patient to demonstrate it back, and if they don't understand it or demonstrate it the way you want, you teach them another part, then you ask them to demonstrate it back, and I'm like, yeah, teach-back methodology. I like the fancy phrasing, but we've been doing that for years. So I like that this is finally coming to the forefront, this teach-back methodology. And it's a huge opportunity for pharmacists to work with our nursing counterparts to help relay the same consistent message in a way that the patient will continue to understand. One of the things that's not captured in this article, but in working with Dr. Kim, I really came to appreciate, is he used to talk a lot about a consistent message to the patient. So he'll talk a lot about when the physician says, this is what's important about your medication. It should be the same thing that the nurse said. This is what's important about your medication. And it should be the same thing that the pharmacist that came into the room said, this is what's important about your medication. And I think that's an incredibly crucial message when we start thinking about patients. Even if you look at statistics about what the average American remembers, they remember usually 3 or 4 things tops. And if you have someone coming in and says, these are the three things you should look at, and then someone else comes in and says, these are the 3 things you should look at, and still a third person, and they're all different, how many of those are they going to remember? It's really going to be the person who caught their eye the most, or who had another more engaging conversation, that then delivers the more important message, or the person who they feel is the most important. And so, I don't know about you, but I'm thinking about my inpatient care practitioners and the physicians, and I think the physicians are much more personable to the patient. And so I thought, well, I appreciate that the physician is going to be the one they remember. Wouldn't it be great if it was the pharmacist that they remembered as their medication? Who said, I remember the pharmacist told me these are the 3 things, right? And then it's just replicated and consistent throughout the day. They identified 9 minimal required information to patients and families points. And there are some really important things in here. One of them is care coordination, which we've talked about a lot. The other one is medication reconciliation and an understanding of medications that they're going home on. Again, they've utilized patient and family-centered care, so making sure that not just the patient is sitting there, but also their families are involved. Are you identifying and reaching out to those families in a way that they want you to, and in a way that they're going to understand? So not the way that you think they might, but are you actually asking the families to get involved and say, when you go home, how is this going to work for you? How can I make this message meaningful? How can I make this come across to you in a way that you understand? And I think that's incredibly important. They might say, you know what, I'm not the person you really want to talk to about this. My daughter-in-law is coming in, and I think you really should let her know. And so those are the things that we have to reach out and ask as practitioners in those areas. The third thing, or the fifth thing, but the third thing that really caught me on the way that they do this is they have 8 Ps that are identified, and there's 6 more because I've only got 2 here. But the 2 that I'm going to pull out for you are the 2 that are related to medications. When you think about what makes for a successful transition of care, focusing on problem medications and focusing on polypharmacy. So are they using a high number of medications? Are they using high-risk medications? And I think this is incredibly crucial. When you think about transitions of care literature and what we know, there's not a lot that we know for certain. What we do know for certain is that high-risk medications continually come up on things that a pharmacist could or should get involved in from a medication standpoint. This is another article that was published in 2011 by Budnitz and colleagues. This one looked at complications in the emergency department, and particularly looking at what kind of emergency hospitalizations, and what medications were associated with those. And building on the high-risk medications we were talking about before, 4 medication classes were identified: warfarin, insulin, oral antiplatelets, and oral hypoglycemics. How many of you are surprised by this list? This is exactly what we look at every day. These are what we know to be high-risk medications, and there's more that are on this list, and I think that we could continue to elucidate those. If you look at them, the implications for this article, and if you go back and read it, which I encourage you to look at as much transitions of care literature as you can, that we should focus on the medication management programs for anticoagulants and diabetes. Coincidentally, many of our hospitals and health systems are putting care programs in place around anticoagulants and diabetes. Now, part of that is because we have some financial motivation, right? So if you think about national patient safety goals, there's now a particular national patient safety goal that focuses on anticoagulants. So that was a great impetus for pharmacy to get involved almost 10 years ago now. If you think about diabetics and the way that we educate and help them, it's also not coincidence that CMS looks at diabetes and looks at the way that you manage it. So it doesn't take a genius to figure out that other people are reading this literature. And what I think is the most compelling is that there's still so few discussions of what we're doing out there. Kathy was talking about you have to document, you have to tell your story. It's the same as when you were interviewing for residency and someone said, so tell me about a time you did this. You have to be able to tell that story. And at one point, because all of you are here, you got really good at telling that story. Right? You could tell I was part of the team, we gave this PowerPoint presentation, my role was to come up with the slides, and this is the outcome of our team, right? It has to be the same. We have to be able to tell that same story for pharmacy. These are the outcomes we are trying to impact. This was my role on the team. This is how we impacted them, and this is how that patient's doing today. It has to be the same story. So how does pharmacy get involved? Or what has pharmacy done so far to get involved? There's 4 different interventions that I'll talk to you about, and there are many more out there. But I'm going to focus on these 4. The first one is Project Red, and you've probably familiarized yourself with this, or at least heard about it. Project Red was a nurse and pharmacist team. A nurse did a lot of what I call the heavy lifting in the hospital, so they did a lot of the identification and initial education. And then there would be a pharmacist that would call 2 to 4 days later, and they would go over, if you read the article, they would highlight information. So they would go back and they would provide that consistent message that Dr. Kim gets all whipped up about. They would provide the consistent message back to the patient. And at the end of this, what's significant is there were fewer readmissions and ED visits in this group at the 30-day point. This is one of the few articles out there that utilizes a pharmacist and has proven outcomes. Is it the only way to do it? I don't think so. I don't know the answer to the only way to do it. But what I do know is that this is one of the few articles out there that actually identifies a pharmacist's role, and it doesn't have us doing everything. It has us doing what's in our area of expertise. So if you think about how you're going to get all your work done in a day, and you want to think about if you're into a practice model initiative and operating at the top of your license. I was trained by Scott Moore, so I should probably tell you I'm a little bit biased. And so I say top of your license probably 3 times a day. If you're on my management team, you say bingo every time I say it. So if you want to operate at the top of your license and be a medication expert, then this is an ideal way to go to your bosses and future employers and say, I think we can do something here in transitions of care. The second is a pharmacist-facilitated hospital discharge program. This one, it was actually conducted by Walker, and it's in the Archives of Internal Medicine, released in 2009. This is a pharmacist-facilitated hospital discharge, looked at medication therapy assessment, and medication discrepancies at discharge were reduced. How many of you have looked at MedRec and said, I've reduced medication discrepancies? Probably the majority. And for those of you that aren't raising your hand, either you're not listening because you're asleep, or you're just not participating, in which case I need you to do both. Everyone who does their job every day identifies a medication discrepancy and fixes it before discharge. At least one. If you think about this, it's important in terms of telling our story. This is kind of the body of the story as you used to be told when you were a student, right? You have your introduction, and you have your body and your conclusion. This is the body of our story. What this isn't is the conclusion. This helps tell the journey. Reducing medication discrepancies, to my knowledge, has not been proven to have any impact on readmissions. Does it do a better job and does it provide better quality? Absolutely. Is it a key component of our story? Absolutely. Does it do anything for readmissions? No. So either we have to find a way to make it meaningful in terms of tying it to readmissions. We may never be able to do that because statistics are beyond me. But we absolutely need to keep doing it, and we need to tell it as part of our story. It has to be part of what we do. It has to be part of when people think of what does a pharmacist do to make my patients' transitions of care better, they make the medication list right. Right? We fix things. That's our job. We fix things. We're problem solvers. I had a nurse in the cancer center come to me the other day and she said, we need another one of this type of pharmacist. Excellent. What do you want their job description to be? She said, well, I need this problem solving done. You could hire anyone for that. Why are you? Well, what else are they going to do? Well, I need them to implement these clinical initiatives that are solving these problems. And I'm like, okay, so you've identified that you need a pharmacist to problem solve. And while I appreciate that that is kind of our bread and butter work, like I'm going to need more to go on because my boss is not going to go for that, right? But I think it's amazing that you can go to leadership and they say, I need a pharmacist to do this. And when you say, for what? They say problem solving. So when you think about the ways we can get involved, we have to make it part of our story. If you think about other ways that pharmacists have got involved, you can see literature around home-based pharmacist-led care management. And I think it's important that we do care management. I'm not entirely sold on this from a pharmacist care management standpoint, and that's okay if you disagree with me. I'm just saying that I'm not entirely sold on it. I'm sitting on the fence. I might be just a late adopter. But there are organizations out there trying it. For example, if you look at Hopkins. Hopkins just trialed a program over the last couple of years, and they had a pharmacist go out into the home of patients and speak with the patients about their medications. They identified horrifying medication discrepancies, life-saving medication discrepancies. If you also work where I work, you know the words sustainable and scalable, and those are also on our management leader list. So I want to know how they intend to scale and sustain that process. And if they can do it, absolutely go for it. If you look at what they do in Australia, community pharmacists in Australia, every patient is assigned a community pharmacist, and those community pharmacists go out into the patient's home and do the exact same thing that Hopkins is talking about. They go out, they go to the patient's home, they talk to them about their medications, they look at everything from the things that we talk about in school, where they're stored, how are they utilizing them, how do they remember to take them. So I don't know about you, but where I went to school, we did things like identify where patients would put their meds to remember to take them. So mine are by the coffee pot, because that's the first thing that happens every day in my house, is I wake up and think, oh my god, I need coffee. And then I go down to the coffee pot and I remember, oh my god, I need Zyrtec. So whatever helps the patient, right? And these are simple things that we know. And for some reason, these are like revolutionary ideas, right? So there are opportunities for pharmacists to get involved. Sustainable and scalable. Those are the two words I want you to keep in mind as we go forward from here. When you think about the way that a pharmacist works and how we can get involved, there's another article that was done by Novak in 2012. And this is looking at pharmacist medication review, particularly on elderly patients. And this was published in Consultant Pharmacy, so it won't surprise you that this is the content. And in this randomized controlled trial, patients who were 60 or older with at least 5 drugs had a significant reduction in drug-related problems, in case you don't know what DRP is, drug-related problems. And I realized when she introduced me that you probably don't know what ACU means, which is ambulatory care units. So just we'll keep this going for the rest of the talk also. When you look at this, there's a significant reduction in drug-related problems after the discharge in patients who have a pharmacist review their medications when they're 60 or older. I was working with Haney on a grant project once, and we were talking about how we were going to stratify high-risk patients. And we struggled with 2 things. One is that when we started looking at all of our criteria, we isolated about 85% of all inpatients. So when you start talking about high risk, and you start naming those classes, even if we went with the ones that we talked about before, so anticoagulants, anti-diabetic medications, I think we added a couple of more to ours. We had a pretty decent list. When you start thinking about those, you start saying, okay, well, what if they're greater than 60? And what if they have, over X number of meds? And you really do get 85% of the inpatient population. But also what we struggled with is how many meds is too many meds? In this article, they chose 5. For our grant proposal, we chose 7. There's other literature that chooses 10. So I don't know that we know what the magic number is. Just pick something and try it. It doesn't really matter what the details are. If you're trying, you can always go back and change something, evolve, continue to get better. Like I said, we use 7, this used 5, there's another one that uses 10. Oh, whoops. I'm new here. When you start thinking specifically about opportunities for pharmacy, I'm going to break these down into a couple of categories. So we'll talk about admission, we'll talk about inpatient, we'll talk about discharge and post-discharge. When you start thinking about the ways that we can get involved, and I'll highlight just a couple of basic bullets, which you guys are probably already familiar with. When you think about admission, this is kind of the baseline. Again, I'll talk about nuts and bolts. This is, in my mind, when I think about nuts and bolts care, it's drug-drug interactions, it's IV to PO switches, it's all the stuff that if you don't do, I'm like, what is wrong with you? These are the things when we look at our profession and we talk about where we're going, and we think about what do we do as a profession, these are the things that I think we should be doing as nuts and bolts. When you think about what are your core deliverables as a pharmacy department, what are the core services that you offer? Every patient that comes in gets these things from us. I think these should be in there. You should be involved somewhere in an admission history. You are a delegatee, right? I love to delegate, so I'm a big fan. Someone acting as on your behalf, or you should be involved in the admission history so that it's done right. When you look at medication reconciliation, we should look at a couple of basic things. Are there errors of omission, which we know, at least in the study we did at Michigan, there were about 60% of patients had an error of omission. Medication adherence, and medication access. So sometimes, and you all have seen this a zillion times on rounds, they'll say, oh, well, this patient's blood pressure is uncontrolled, increase their dose. And you go back and talk to the patient and you find out that their dose is fine, they don't take it. Or they can only get it every 60 days, so they take half. So these are the things we need to talk about as pharmacists in the healthcare team. Think about adverse drug events. So is it a drug event that brought them into your hospital? What is the role of drug events as they enter in? And then optimizing the medication regimen. While they're inpatient, and I was just talking to some people who are interested in doing inpatient care practitioner. In fact, I think it's Megan. Did I get your name wrong? Megan. I'm nervous, so I forget names. But so I was talking to Megan, she said she's going to do a PGY2 and PEDS. I thought that's awesome. That's an excellent opportunity for transitions of care. In fact, some of our greatest strides have been made in pediatric care. When you think about inpatient opportunities, optimizing the medication regimen is, again, nuts and bolts. Initiate medications that need to be initiated. Discontinue medications that need to be discontinued. And modify doses or simplify the medication regimen. How many of you in your health systems or where you work have the ability or responsibility to initiate, modify, and discontinue therapy? Raise your hands a little bit higher. Okay, so a very, very small number of you. If you are working in an area where you have any kind of access to the leaders of your department, I really encourage you to look at this as an opportunity. Initiate, modify, discontinue medications in your hospital setting. It's what we're good at. It goes back to kind of the provider thing. On the inpatient side, this is, in my mind, the equivalent of prescribing. You're initiating, modifying, discontinuing. And many hospitals will allow you to do this through P&T protocols or things like that, and really work with your leadership to see if you can get that done. On the inpatient side also, you can identify barriers to learning for the patient, look at their medication management, look at their disease self-management, look at their adherence, and maybe provide tools. As an administrator, I look at this blister packs and I'm like cringing, right? Because I'm trying to figure out how we would get that done. That doesn't mean that it's not the right thing to do for the patient. And it doesn't mean that there might not be something in the middle. So all of these things that come up, and there is some data to support some of these things. It doesn't mean that it's the best thing for you or that it's the worst thing for you based on the fact that it might be difficult, but it means it's something to try and look at. And so I want you, these are mostly just to get you thinking about what you can do in your practice to help the transitions of care. This is where a lot of the literature focuses, is on the discharge. And that makes sense because readmissions are one of our primary payment motivators. There is a lot of opportunity around medication reconciliation on the discharge, in the discharge realm. When you all are providing medication education at discharge, do you provide it before the patient is discharged? So raise your hand if it's before the patient is discharged, like maybe a week ahead of time, a couple of days leading up. Okay, so a couple of hands. How many of you do it like maybe the day of or right before they leave? Okay, and this I would include even if they're coming to your discharge pharmacy and it's done in the discharge pharmacy, day of. How many of you do some kind of follow-up call? Okay, we'll talk a little bit about all of those. If we look at the way that medication reconciliation is provided, and this is nationally, there's a huge discrepancy and disconnect in the way that we do it. And the literature that supports it is not very robust in terms of the timing. I would love to know the perfect time to provide medication education. And so I think about this, there are, if you look at Mayo Clinic in Rochester, Minnesota, they have instituted a program because they have a central pharmacy that does some of their discharge and other fills. When the patient comes down and they're waiting, they do the medication education right there while the patient's waiting. And so this sticks in my mind partly because I get a lot of calls around turnaround time for our community pharmacies. But I'm thinking, what a great distractor. Like the patient would have something meaningful and not realize that we're taking forever. Right? This is genius. But I really like the idea. Imagine if you're a patient and you've been in the hospital for maybe 6 or 7 or 14 days, and now the only thing between you and your own bed is me. And I'd really like to tell you about these 14 medications we just discharged you on. How interested are you in learning about those medications? Not. Imagine if you're still up on the floor and you're waiting for your cab. I don't know about you, but I'm about 20 to 30 minutes before a plane lands, I'm antsy. I'm like waiting, right? And so I can imagine sitting there in my hospital bed, waiting for a taxi cab, and the last thing I want to do is talk to another person about anything. Just get me out of the hospital. Is there a better way? I can tell you in that same grant proposal that Amy and I worked on, we said, you know what, pharmacists should talk to these patients well before they're discharged. And then we can do kind of a refresher. Think about Project Red. They provided medication education, and then 2 to 4 days later, a pharmacist called. You provide the initial information, you come back, and you reaffirm. Right? It's kind of a prelude to where a pharmacist, as Kathy was talking about, like might get involved in the community setting, and they can come back and say the same things that you said. Right? Like, how helpful would this be? So we talk about medication reconciliation, medication education on the outpatient and discharge. It's incredibly important. Match discharge follow-up to need. So are we following everyone? Are we stratifying? Do some people get a phone call? Some people get that pharmacist coming to their home? I'm really excited. One of our pharmacists was just awarded an innovation grant at Michigan to do some pharmacist education via an iPad. So these are like the cool things that I think we could do. We really haven't found a way to use technology effectively in pharmacy yet in this manner. And then these are some of the baseline stuff that you would want to look at. Post-discharge, follow-up visit or phone call. And there's a lot of literature around follow-up visits and phone calls. I'm still a skeptic, and again, I might just be a late adopter of the follow-up phone call. I remember having a conversation with one of my favorite providers, and she's telling me about, this is how we're successful in the outpatient setting, is that we schedule an appointment to call the patient. And I'm thinking, well, yeah. She said, yeah, we tried calling, just out of the blue, and patients didn't want to talk to us. And I'm thinking, of course, I don't even answer my phone if I don't know the number. And so I'm thinking about how patients think. And it's possible, it is absolutely possible, that you'll have a patient who has really nothing else to do except answer the phone and talk to you all day. In which case, they'll talk to you all day. But many people are busy, and even people who have complex care needs are busy, and they may be busier. And so it makes a lot of sense to say, you know what, I'm going to call you Thursday at 2 p.m. And I've actually had other conversations with other practitioners in a similar setting that said, you know what, I didn't call them until 2:05 and they were already calling me. Because they come to expect that care. And so we think about the follow-up visit or phone call. I think it's absolutely worth trying. I really encourage you to look at what's most meaningful for the patient and to ask them, what is going to be the best way for me to contact you? Maybe it's via email, maybe it's via your MyChart or MyPortal. So when you talk about some of the things driving technology, these are some of the ways to get involved. Look at what you can do in terms of their medication therapy management. looking at simplification, looking at optimization, and then making sure, and this is crucial, that we communicate medical information to the next level of provider. One of the reasons that I think the PCMH model works is because it is integrated with that next level of provider. That communication is constant, and it's integrated, it works. Even if you think about, okay, so let's say that I am working in inpatient care, and I want to let their pharmacist know, maybe they have a primary pharmacist somewhere. How do I let their pharmacist know? Do I call the Walgreens in Marquette and say, I'm monkeying around with your patient's meds, here's what I did? How do I get that information to them? And I don't know that we have a good way of doing that yet. Is there a way that we can operate even within our own pharmacy world to make this care provided more meaningful? So yes, we send a communication to the PCP, and physicians often do that. Can we have like a parallel path for the way pharmacists would do it? And Kathy talked a little bit about metrics, but I'm going to bring up a couple, just these three, because I think they're big drivers. One is the CMS and National Committee for Quality Assurance and readmission. So CMS, obviously Medicare patients. National Committee for Quality Assurance, similar, it's all cause and it's commercial and Medicare, which hits all of our patients. And I'm not saying that 30-day readmission is the best measure out there, but it's what's out there. It's what drives cost, it's what drives penalties. So you have to know that it exists. The National Quality Forum has endorsed this timely transition of transition record, which I like to try and say fast. But the timely transmission of transition record means that did you tell someone caring for this patient, usually their next level of care, the community provider, about the patient within 24 hours? So I want you to think about how the medical record process works in your health system. How many of you know how the medical record process works in your health system? 2. That's fine. So when you think about the way the medical record process works, so for the 2 of you that know how it works, give me a guess as to when a physician has to sign off on a record. What's their drop-dead date before HIM starts calling them?
7 days.
7 days. That's a good guess. I've been in health systems where it's up to 3 weeks. So think about getting a transition to another care provider within 24 hours. This is a huge challenge. How are we going to do it? Is it a better measure? Possibly. Stage 2 of meaningful use. This is important, and this is incredibly important for your physician providers, because this electronic summary of care drives the incentives that your providers are paid. And so it's possible to think that every provider out there will eventually get on board because they want to get paid. And so we have to start thinking about how to better use the care record and look at our electronic summaries. It's really interesting. How many of you are up on an Epic product? Okay, so a fairly decent amount. Have any of you ever used the after-visit summary? Of that information, how many would you say 80% of it is helpful? 70%? 50%? 30? 25? Can I get 20% of the information is helpful? No one's raising their hand. So if you think about the way that so yes, we've met the meaningful use. Is it meaningful to a patient? It's really interesting. So if you think about the way that Epic provides information on medications in particular, and I'm going to pick on Epic even though I work with all of them, Epic does this thing where they have like your continuing medications and they have your stop taking medications. And if you go to change a med, you have to stop taking and then start taking. And it was really interesting to me. One of the things that I read in Dr. Kim's article is they have this format that they suggest for MedRec. And it has the medications you're taking and the medications that you're not taking, and then the medications that you've discontinued. And I thought, what a great idea that failed in this one arena. Because when you think about how the patient sees this, they don't see it in the order that they need to. And so we have to do things even within our own technology now to make it meaningful for a patient. But are they meeting meaningful use? Yes. And is it better than what we had before? Absolutely. So this is where I want you guys to start thinking. Considerations and opportunities, or why haven't we done more? Because it's hard. I couldn't put that on the slide. Because it's hard. So how many of you work in, I would say, psychiatry, oncology, even heme, cardiology, critical care, ambulatory care? These are what I would call like the really difficult arenas, right? So these are complex patients. Nothing easy about them. I would say pediatrics, except for that I've avoided pediatrics my whole life because it's that hard. So if you think about almost all of our patients are complex. There's not really any group that falls out. And so when you think about it, it's going to be hard. Sometimes we have a patient who will stay because their family isn't ready for them to go home. How many of you have had a patient who stayed because their family couldn't make a care decision? That's almost everybody. So when you think about the psychosocial and family complexities that exist, it means we work with social work very much to get these things resolved. You think about the fact that transitions are often urgent and unplanned. How many of you would say that you have an incredibly well-oiled, planned discharge machine? Again, no one's raising their hand. I don't know about where you work, but where I've worked before, it's a very unplanned event. All of a sudden, everyone's like, oh my God, they're discharging. We knew about this for days, right? Like someone, somewhere had an idea that maybe 2 to 3 days now the patient was going to go home. Why aren't we talking about this? What can we do ahead of time? What can we do to help this patient get out quickly? And then you think about all of this and the healthcare complexities. And I've only listed communication and technology. So when you think about what holds us up, some of it is medication related, some of it is, absolutely within our realm. A lot of it isn't. And so we have to figure out how we partner and collaborate and communicate to overcome some of these. Communication, and one thing I didn't list here, but I will note, is finances and billing. So if you're a patient and you're receiving medical bills, that's a complexity we didn't even talk about in terms of transitions of care and how that might drive their decisions going forward. Technology. So we talked a lot about some cool things that are coming up. I'm going to talk about a little bit of what we've done so far. So automated alerts and triggers. How many of you within your healthcare system use some kind of automated alert to page or otherwise let a provider know that this patient needs your care? So a handful. I think this is a really great idea. I'm not a huge fan of working on alerts of things that as an isolated measure, but I think when you're talking about transitions of care, I think it's a really great opportunity because you can input the high-risk criteria, and so at least if you catch anybody, you're catching those people who probably need it most. You can look at numbers of meds. Can you set an alert for numbers of meds? Can you work with nursing to develop a partnership where they let you know, hey, this patient on our floor is a train wreck, and we need you to come look at them. Are you using triggers and automated alerts? This is a great backup plan, in addition to your comprehensive patient review, which I know all of you do on a daily basis. Is this part of your core services? Where are you documenting? And you have to be documenting. Kathy kind of alluded to this idea of provider status and getting paid for our services, but I would say on the inpatient side, it's even more important. My first tenet of faith is that if you're not getting paid for it, it's not important. When a patient looks at their medical bill, do you think they're like, oh, that was really important, I'm glad I got that for free? They look at what was the most expensive. How many of you bought a TV or a car, and you were between two, and you went with one that was a little bit more expensive because you thought that might be a better brand? You have to get paid. If it's not important, it doesn't have value. And if you're not getting paid, then how do you know it's important? Someone outside of you has to recognize that what you're doing is important, and therefore worth paying for. And so I think this plays really well into what Amy will talk about. If you're getting paid, it's important. If you're not getting paid, and on the inpatient side, it's all DRG, so that's not going to happen, you have to document. We have to tell our story. So some of us use things like Theradoc, some of us use iVents and Epic. There are a lot of different systems out there. I encourage you to find whatever works for you. Electronic communication. So we talked a little about the discharge documents. Is it meaningful for the patient, and is it meaningful for the provider? How many of you have been shopping recently where they said, would you like me to email you your receipt? Right? I love this. Wouldn't it be great if we could just email or go into my portal, and the patient, some of us are doing this, the patient could just say, oh, this is everything that happened to me. Or the patient's care provider could look and say, this is everything that happened while they were inpatient. And I can follow up on this. There's a lot of discussion around the idea of electronic communication. I know for some providers this has become somewhat disheartening because there's such a flood of information. It's hard to identify what's relevant and what's not. But it is an opportunity to get better going forward. Rounding reports, we do this a little bit electronically. I don't know about you, I have a med team that still uses an Excel spreadsheet. And I'm like, really? An Excel spreadsheet? I guess it's better than handwritten. I have another med team that they use a handwritten. I'm like, how do you know who's following on that team? And they're like, oh, it's whoever we hand this to. I'm like, how am I supposed to know in the discharge pharmacy which PA to call if my only record is the fact that you handed that pad of paper to someone? So these are things that like increase transitions of care. So I'm going to go through really quickly a couple of things that we're doing in the Mission, which I love this idea because I'm new here. I grew up in Arizona and we didn't have any cool shape assorted with SC. This is awesome. Whenever I get back from flying, I'm like, Mom, safe back in the Mission. Right? Like, I think this is cool. So I'm going to talk a little bit about Beaumont, just to balance it out, because I'm going to talk a lot about Michigan. And I talk about Beaumont because I like what's going on there. I'm biased, but I think Kathy's awesome. But when we talk about Beaumont, this is something they're doing with their unit-based services, and this is just a quick, if you have more questions, please follow up with people who work there. But these are some of the things that we talk about are happening with the unit-based service. And if you look at the ones that I've kind of put in red, these are things that come under transitions of care, right? So discharge counseling, some documentation and follow-up, review of their after-visit summary, teaching, they're checking for scripts for patients so that they don't have to wait, they're looking at their patients at discharge, discharge prescription service, patient medication information handout. These are some really great baseline things to start with. And so if you're looking for a place to start, I think this is a really great way to go. The other thing is that if you're into the practice model, this is really in line with the practice model stuff. Again, I'm biased, I think it's great. But so again, if you're looking for ways to marry the two, I encourage you to talk to people who work there. So these are a couple of the things we're working on from our perspective at the University of Michigan, and you'll hear much more about some of these coming up later from Amy, and so I'll keep going. One of the things that we're spending a lot of time on is medication reconciliation. This particular slide is about our outpatient geriatric service, and this was started by one of our pharmacist clinicians, and she utilizes technicians and interns to do pre-call for these patients. She's also done a lot of stuff with the medical staff in general, in terms of MA training and things like that. But the moral of the story is that they've had a better accuracy rate and a decrease in errors in history because of this education and utilization of interns and technicians in this role. And so there are a lot of opportunity to get other people involved. If you look at, so I'm going to spend a minute talking about restricted distribution. Kathy talked about restricted distribution and particularly oncology agents. We actually built an entire program around oral oncology agents at our health system, particularly looking at not just symptom management, but what started as symptom management turned into access. And so I really think there's a lot of opportunity to look at how you can make this more streamlined at your health system. And in addition to making sure they get it, make sure that you're following up on those symptoms. Again, triggers, medication management, all that kind of stuff. And we just finished a pilot using students for MedRec in our cancer center, in our infusion center. And so we'll be renewing that going forward for the next year. And then this is another inpatient care, direct care student MedRec. And I'm going to harp a little bit on students in terms of utilization because they have to be utilized. We have, if you think about the number of students, and we have armies of students coming into our healthcare system, we have to find a way to make these moments meaningful for the students and also help share the load of the patients because we can't do it all on our own. 12,000 pharmacists, if you compare that to the number of patients that exist, the mathematics are just not going to work out for you. We have to find a way to extend ourselves, just like we're asking physicians to utilize us as an extender. The last one I'm going to talk about is the last two are around transitions of care. One is a technician program that started out as a pilot, which is now a role for us. And this technician started out looking at admission histories and outpatient medications, and again, made tons of changes in conjunction with pharmacists and solved all kinds of medication problems. And really, at the end of that pilot, we found that what made the most difference to both the patients and the providers was the access issue anticipation. We talked to them a lot. We said, what was meaningful from a provider standpoint, and they over and over again said, we really like that you get the PA taken care of. The other great thing is if you're an inpatient care leader, is you might be able to get your outpatient care administrators to pay for this because it helps take the burden off their pharmacy when it gets there. So just if any of their, for example, I pay for this technician, and I'm outpatient care. Our cardiology and heart failure team, this is the same idea of the first two. So taking that medication reconciliation and making sure that we're doing admission histories and taking that component and moving forward with students. And what I've listed on the second bullet are responses from a student that I asked, so how's that going? And that student was very clearly able to articulate the benefits of that program, both for the patient and for the student. And so I think it has a lot of potential. The things I want you to take home: collaboration, communication, anticipation, and thinking about MedRec and MedEd at just kind of nuts and bolts type things that we do as we seek to provide patient and family-centered care and care transitions. At this time, I think I have like 10 minutes for questions because I talk really fast. So if any of you have questions, please feel free to ask. Sir?
Early on, I think there was a question about how many of us have called, say, an outpatient pharmacy, and or how many of us who had some retail experience have received those calls. Working in the emergency department, I know I call often, and we may need to work as a profession on better collaboration there, because those outpatient pharmacists are generally not that happy to spend 5 minutes on the phone with us going through a complex medication regimen.
I agree.
So
he's saying we might need to work on our peer-to-peer communication. And I think that's an absolutely excellent point. I think it's a struggle when we start talking about, just like we have demands on our care. The measures of a retail pharmacist are often different than I think what they could be. And so when you start talking about it, sometimes I'll start with the technician or an intern, and then if I really need to, I'll go to a pharmacist, just because I know it's going to be one of those conversations that's sometimes a crucial conversation. And so I'll start with kind of a technician or intern. But you're right, we absolutely could do a better job from a communication standpoint. The one thing that I think we could, and that's across the board from outpatient to inpatient in general, but I think community pharmacy in particular.
We talked a little bit about the importance of obtaining approval to do discontinuation of medications while they're in the inpatient setting. Do you guys do any communication with their primary care? So if Dr. Smith started omeprazole and you feel that it isn't indicated anymore and it meets your inpatient criteria, do you do any communication with the outpatient provider that started that medication?
I can't think of a service that does it, not to say it's not happening, but I'm not aware of any of our inpatient care teams that currently work with the outpatient providers in that manner. Have you, either of you, aware of any of those? Yeah, I can't think of anyone. I know at Abbott Northwestern in Minneapolis, they were trialing a similar idea, focused mostly on skilled nursing facilities, but looking at that communication between inpatient and outpatient. And so there's a woman there, Christy Gullickson, who would be a good person to talk to.
So we may not get the direct communication from inpatient provider to the outpatient, but that's one of the roles for the ambulatory care pharmacist who makes post-transition calls to follow up with the patient. So Lindsay alluded to the ambulatory care pharmacist in geriatric, and we have our pharmacy resident here, Paul, who also involved in that clinic, and we actually, part of the assessment is looking not only through med reconciliation, but doing comprehensive med review. So during that process, you're looking for appropriate indications, are there, so that patient doesn't really need omeprazole. That would be the recommendation the pharmacist would make to the PCP at the follow-up visit for them to address.
Could you summarize the pharmacy involvement with the average inpatient encounter?
I'm giggling a little bit because I think on the inpatient side, I think my summary would be different based on disease state or team. What we've done is look at outcomes for those patients and identify what's most important for many of our teams, and so I think you would see a wide variety. And so I think, some of our basics are going to be what I talked about earlier in terms of nuts and bolts. There are teams that are actively involved in transitions of care for patients in terms of access, in terms of med rec, in terms of admission histories. There are other teams that aren't actively involved consistently in all of those things. So I would love to tell you that, yes, if you come into the University of Michigan, this is the thing that happens for all patients, but I think we're still working through some of that.
I was just going to say it sounded like such a good idea to make an appointment to call a patient, but I was just thinking the reality, it seems like the type of pilot programs we've had, we call when it's convenient, when we have a minute to call somebody, because you really don't know what Thursday is going to look like. But it's nice to know somebody is doing it.
Yeah, and I think, while our proposal wasn't accepted, in our proposal we had talked about hiring a pharmacy technician to coordinate that follow-up call and care. So, we talk about, does the patient have do they have an appointment on the outside? We also have nurses looking at PCP appointments, but we actually wanted to have a technician make sure that that patient has an appointment with their primary care pharmacist, their patient-centered medical home pharmacist, because many of our patients are part of one of our PCMH registries. And so we wanted to make sure that they had a scheduled appointment. It is important, I think, and technicians, we could pay them a lot more. And so they're a great resource from an administrative standpoint, is can you somehow fund a technician to even coordinate that on a certain group of patients? If you're looking at sustainability and scalability, that may be one way of doing it. I think it's really hard. I'll step back from Michigan and get on my own soapbox for a minute. I think it's important to recognize that for many of our components of care, we do it when it's convenient for us as a profession, and not necessarily when it's convenient for a patient as a profession. And so that may be one of the things over the next 20 to 30 years that we see change.
Yeah, do you have any problems with other practitioners doing a lot of follow-up calls along with you and the patients getting sort of annoyed with it?
So do patients get annoyed when we call all the time? So we didn't in our particular practice, but I have heard anecdotes from other health systems where they've encountered that. We, in our practice, we didn't do follow-up calls outside of a nurse follow-up call, and so we haven't encountered that. But I have talked to other health systems throughout the country that have encountered where they have, maybe the internal medicine nurse calls to verify as part of the internal medicine team. The primary care nurse calls to verify as part of the PCMH, and then a pharmacist calls. And so that's why, you heard a little bit of skepticism around me talk about phone calls, and I'm not entirely convinced that's the best way to do it unless you can do it in a very integrated, structured way. Again, I don't answer the phone unless I know who is calling, and I'm definitely not answering if you're the third person to call from the University of Michigan today.
Had some informal discussions with some practitioners about who the best person is to do some of the discharge counseling, if you will, whether it's more effective to do it from a push standpoint as they're leaving the hospital, or if it would actually be more effective as you're pulling them back into the primary care with so much consolidation in the primary care sectors that seems to be involved in the larger clinic, where maybe if there was a pharmacist there, they would have access to a lot of the patient's records and could be helping pull that back into the clinic and doing some of the coordination of care and counseling at that point, post-discharge, rather than that hurry, oh my God, they're being discharged time we talked about.
Yeah, I think from a push or pull standpoint, I've seen it both ways. So in our particular setting, I think we do a lot of pull in terms of our PCMH patients. I would say that for those patients who aren't part of a clinic or aren't, if you're a health system serving a large rural region, it's likely that they may not come back to you for their care. If you look at some of the things that have been done, Cleveland Clinic is doing some bedside medication education. Fairview in Minneapolis is doing some, particularly in their pediatric population, and that's much more push. I'm a systems person, and so I want to know that it's guaranteed every time. And so the pull system makes me uncomfortable a little bit just because I'm relying so much on the pull. And so I think if I had, unlimited resources, I would go for both. But if you're talking about high-risk patients, then high-risk patients are likely to be in your PCMH or in your clinics, and so that may be a way of relying on it for that stratification of patient. All right. Well, I'll be around, so if you guys have further questions, let me know. I think at this point I'll try and keep us on track.